Moving into session 7, learnings from CCDS patient families. So we're going to hear from a variety of speakers in this session. There are some very personal perspectives, as well as some conversations about outcomes, understanding the perspective of caregivers, patient meaningful outcomes, demographics related to CCDS, families, and the like. I'd like to invite our first speaker for this session. It's my pleasure to welcome Kim Soesbergen to give her talk. Just a little bit about her. Kim is a sister of a creatine transporter deficiency patient. This personal experience, together with her background, she is currently obtaining a degree in neurosciences, inspired her to develop a CTD guideline. This guideline attempts to bridge the gap between science and society by explaining the disease in an understandable manner.
So, as a short introduction, my name is Kim. I'm from Amsterdam, the Netherlands. And I did a bachelor's in psychobiology at the University of Amsterdam, and I'm currently doing a master's in neurosciences at another university in Amsterdam. And as a last part of this master's internship, I'm currently researching Alzheimer's disease at Mount Sinai in New York. So from this you can probably tell that I have an interest in the brain, but besides this I also have a brother with CTD, and he's 16, you can see him over here. And my goal for today is to try and connect science and society. So before I start talking about my project, I'd like to know a little bit more about you. I've already spoken to a few of you, but I'm wondering who of you is a parent or a caregiver of a CTD patient? Okay, quite a lot. And who of you is a researcher or a medical expert for a CTD patient? Okay. And now for all of you, have you yourself ever experienced difficulties understanding this disease, or have you ever seen someone else experience difficulties? Okay, I think that's about the same as what I saw in my project. So in my project, I found that more than half of the parents or caregivers experience difficulties understanding CTD. And this is actually the reason for me doing this project. So the idea of my project was to write a guide, which was a paper which included as much information about CTD as possible, and to have this written in an understandable manner, so that people who don't have a background in science or medical fields could also understand. So this led to this guide. And when I started writing the guide, I soon came across many questions which were hard to answer. So I decided to do a little questionnaire, which some of you might actually have seen. And in this questionnaire, I could then ask for a bit more background about the patients, and I could also ask parents and caregivers what they would like to see in such a guide. So this led to this questionnaire, and I got a total of 33 responses on the English version, and then another 8 at the Dutch version. So a total of 41 responses. So today I'd like to walk you through some of the results of this questionnaire, and then also walk you through the guide to give you an idea of what's actually in there. So first of all, I asked parents and caregivers who filled in the questionnaire who gave the diagnosis of CTD. So for most people this was a specialist, so for example a neurologist being expert in the brain, or a genetic expert knowing all about mutations and DNA. Now for some other patients this was a child doctor or general practitioner who gave the diagnosis. As the next question, I asked whether a patient receives therapy. For more than half of the patients this was the case. And for another large part of the patients, the patient had received therapy in the past but wasn't currently receiving therapy. And then for the kinds of therapy that they received, It was mostly physical therapy, which was the case for a bit less than half of the patients. And then some other patients also received speech therapy and occupational therapy, and a small portion of patients received behavioral therapy. I then asked whether patients used medication. So almost half of the patients used some form of medication to control epileptic seizures. And a lot of patients also used supplements. And then there were some other medications which were found, such as medication for behavioral issues or sleep and anxiety. And then I was wondering, what is the patient like? How is he doing? What is his or her situation? So I asked about whether a patient was in regular education or in special education. And for the largest part of the patients, they were in special education. And then there were 2 patients who had a combination of regular and special education. And there were 2 patients who had regular education. And then for the patients who are not within the school age, most of them went to a care facility. A lot of them also had own activities, so for example, painting or playing sports or being outside. And then 1 patient here had paid work. So now that you have a little bit of an idea of the results of the questionnaire, I'd like to walk you through the guide. So I started the guide with an explanation of CTD itself. So what's the name, what does this disease actually mean, and how does it work? I then digged a little further into the biological background. So I wrote a bit about the mutations and added some images. And then I moved on to what these biological things, these mutations actually caused. So what are the symptoms? Then I had 2 smaller parts, one about diagnostics. So how can CTD be diagnosed, which you heard about a lot already. And then another small part about treatment. And after that I moved on to the guidance part. And this is a part which includes a bit of information from the questionnaire, and it actually walks someone through like what is it like to actually receive a diagnosis, and what actually is something you could keep in mind, and where can you find more information, where can you find other parents who have a kid with the same disease. And then I rounded off with a bit about research. So this includes some information about past research, but also some about ongoing research. And I can definitely upload it already after this symposium. So that was the guide. As my next steps, the first one is something I'm working on already. So this is to distribute the guide. I posted an online version of the guide on the Facebook group for parents of CTD patients. And I emailed the online version also to some people who filled in the questionnaire. And I posted an online version on my LinkedIn page. And if any of you wants to receive an online version, please let me know. And as a second aim, I'd like to also to have the guide received by specialists or doctors, so that if they have a patient with CTD, they could refer to this guide as a piece of information. So as another next step, I'd like to update the guide when necessary, so especially after these kind of symposiums, when a lot of new information is found, I'd like to update it, especially the research part. And as a last aim, I'd like to translate the guide to another Dutch version, because a lot of Dutch people have an interest in this, and in such a version I could also add some practical or financial matters that are specific to this country. So that's it. I'd like to thank 2 experts, specifically Dr. Jideke van den Kamp and Dr. Peter van Hasselt. These are 2 people who reviewed the guide to give it a bit of better quality. And I'd like to thank ACD for having me, and all of you for your attention.
Thank you so much, Kim. It's a wonderful effort, and it's so nice to see another researcher with a family background get into this, because Everything about this that motivates us, the hope, the future is really represented when a family member actually takes up this work. Okay, next up I'd like to welcome Dr. Judith Miller. Dr. Miller is a clinical psychologist with 25 years of experience in developmental disorders. She is the coordinating principal investigator for the Vigilance observational study of creatine transporter deficiency. She is also the clinical training director at the Center for Autism Research and the associate director for leadership in education in neurodevelopmental disorders program at CHOP. Her talk today is titled Measuring Family Adjustments and Accommodations in Intellectual and Developmental Disorders.
Thank you. Good afternoon. That was a great lunch and a really terrific guide. I really was excited to hear about that, so thank you for sharing that. Okay, so I am going to talk today not about Vigilance. I've come and talked about the Vigilance study before, but this is a separate project that's kind of an offshoot, and it came about from not only our experience with the CTD families, but a host of other patient groups that we've worked with over many years now. What we wanted to do was really to capture more about the family experience and some things that are not really well studied and well measured at this point. So that's what we'll be presenting today. I've seen somebody do that. How do you do this? Might be the other one. No. This is a clicker? Oh. Nice. Okay. All right. To go backward. Okay. All right. So what we wanted to measure is accommodation, parent accommodation, in all of its forms. Some of the things that the reason we wanted to do that will become hopefully clear in the next slide, but we know that families adjust, right? Humans adjust to everything. So some of the ways that caregivers adjust to their children, whether they have a disease or not, are the same, and some are different when there's an illness or a chronic condition involved. So, okay. Yeah, I did miss the background. Okay, I thought I was missing something. Okay, so you got a preview now of some of the things that we wanted to measure with accommodation, but the underlying reason for trying to measure this was to look at caregiver stress. We know stress is a clinically useful measure for a variety of reasons, not only in a patient, but also in their family and the people who are caring for that person. But as I mentioned, everyone adjusts to their situation to maximize success and reduce stress. So what I had found in a lot of families that I worked with was that they would say things like, I have a child with severe intellectual disability or severe behavior challenges, and part of the way that we changed our family is we don't go out very much. We don't go to restaurants, or we don't take vacations because it's too hard to try to find a situation that works really well for our child and our family. So they have accommodated to their situation by not doing things, and so their day-to-day stress has gone down, but it has come at this other cost. And that may be fine, but that may also have some unintended set of consequences for the family. So we really wanted to measure that a little bit in more detail and just really learn about it, but also consider that that may be an understood area that we need to be able to provide families with some more support. Okay, so most of the measures right now that measure caregiver stress were designed for situations where maybe there is a difficult parent-child relation. So some of the biggest measures that are out there are for situations where there's been a rift in the relationship. Like the child is having a lot of oppositional behavior, the parent and child are not getting along, there's, it can be escalating to like conduct problems and things like that, which can be very stressful, but that's not the same situation and it's not the same kind of stress as a family where there's a child with a significant illness or a chronic neurodevelopmental disorder. So, and I think there may be some differences in the type of stress and the type of accommodations that families with neurodevelopmental disabilities that are also associated with intellectual disability may have that are different than families with neurodevelopmental disabilities that don't experience intellectual disability. So we wanted to sort of be able to tease that apart a little bit. Okay, so how do caregivers accommodate? There are many caregivers in the room, so if I'm missing something, I would love your feedback. But some of the ways that we know parents accommodate is they change day-to-day behaviors. So they reduce the demands on the child, they help a lot with daily tasks. If a child needs something, they kind of acquiesce. They might avoid going places that are difficult or avoid exposing their child to difficult situations. And they spend a lot of time caring for their child. So they're going to appointments, they're calling about resources. So there's a lot of day-to-day things that happen to accommodate a child. And then within the family, there are often big restructures that happen. So there are changes in career decisions. A lot of parents, maybe both parents don't work anymore, or they change the type of work they're doing. Their financial priorities have to be shifted. Some families enjoy a lot of extended family support, some don't. And some have, even within the family, they have to restructure what's happening with their other children. But we also know that a lot of families describe how part of the accommodation or part of what happens when you have a child with special needs is that you participate in a new community that you never would have been part of. Like most of the people in this room would probably never know each other, but for this thing that brings us all together. And for many families, that turns into a really important part of their life, and it becomes a source of purpose and meaning and enjoyment. And we have a lot of families who talk about like they love being part of the community that they're part of now. They meet people they never would have met. They do advocacy that they would never have had an opportunity to do, and that's a big part of their experience as well. Okay, so we decided to develop some items around this with these kind of themes. We wanted to ask about the child's behavior, and we wanted to get at, when I say child, I mean across the age span, so adult children as well. We wanted to get some measure of the child's behavior, the impact on the daily routines, any changes in the caregiver's long-term plans, and if there were new opportunities that the family had been made available. We wrote a bunch of items. We got feedback from lots of people, clinicians, parents, and a biostatistician about how the items were worded. Then we put it together. We ended up with 133 items. That's probably too many for just a regular questionnaire. You just want to take periodically. But when you're starting a measure like this, you usually go big and you have lots of items so that over time you can whittle it away and find things that are redundant and get rid of them. So for parent accommodation, these are examples of some of the items we have. Like I've altered my schedule around my child's services. I avoid taking my child on errands. I do things that he knows how to do, but I help because that helps it go along more quickly. And then some other items around family accommodation and a whole section on positive outlook and things that may have come in a positive way. Okay, so then we distributed it to as many parent advocacy groups as we could, including ACD, and we got 489 caregiver responses. Again, we were going for any child, age, any level of ability. We recruited from clinics at CHOP, NIH, and at Rush, and parent advocacy groups across the country. We had people complete both an online questionnaire and a feedback survey. So here's our sample. You'll see there's not a ton of kids with CTD. many of the CTD families are in the Vigilance Study, and so we're collecting this measure through that, so that's a separate source of data collection. But we will be coming back to ACD when we have the next version of the measure, and so I hope people in this group will participate like they have before. Okay, so as I broke our sample down into the group with an intellectual disability and the group without. We have about, and I'll focus on the kids with an intellectual disability. We have about 200 of them. The average age was almost 9, and then you can see the breakdown of disability groups. Okay, so in general, we got really positive feedback from the families. Most 88%, if you can see on the second thing, 88% of the families thought the overall impression of the measure was that it was pretty good or excellent, and around the vast majority of parents also thought that it did a good job of describing daily life at home, and also did a good job of describing what it's like, describing their child. So I think we were on the right track, but we did get we got some really helpful feedback, both on things that seemed to be helpful and maybe some new ideas. So we got a lot of responses that parents really appreciated the opportunity to have something like this measured. And so there were several comments around the theme of this first one, where this is more important than people may recognize, and just some gratitude for taking the time to understand the caregiver perspective. We got a lot of comments about parent and caregiver mental health, and we got more comments about that in the group with IDD than we did in the group without IDD. So I do think that's something to keep in mind, is that many parents said, please measure that more, and gave some pretty specific examples about how mental health can be affected. And I thought this one was particularly good. You know, we think a lot about the medical trauma to the children, but the medical trauma to the caregiver is also very real and, impacts your life. Okay. And then we tried to make the measure something that would be applicable across all ages, but we definitely had lots of families respond that my kid would be really different if I was filling this out 3 years ago. And we wanted it to be a current measure. If you gave it at different time points, then you could track someone's changes over time. But a lot of parents really wanted to be able to describe that and say, this is, right now, is different than it used to be, and somehow to be able to incorporate that into the current, their current responses. So I think figuring out a way to do that would be helpful. And then, we asked a lot of questions about things that we thought would be sort of positive, and wanted to just remember that all families are accommodating and finding fun. And one of the great things about humans is that we're generally a positive group of species. We're generally a positive species. And so even if we're in pretty terrible situations, we tend to find something fun about it, or something, we tend to make ourselves happy, even in really, really difficult circumstances. And so I didn't want to dismiss that and say, I wanted to identify that, but then also just recognize that's a human phenomenon. So it's not okay to say, well, even though these families are having a really rough time, they're reporting that they're happy. Everybody will report they're happy. That doesn't mean that we shouldn't find ways to provide support and find ways to improve everybody's situation. But I thought it was interesting to have that we got several comments about some of the items where we said, like, my child is fun to be with, and parents would say yes until they're not. There's all of that is happening at the same time. And so I think coming up with some ways to sort of describe that a little better would be good. Okay, so our next steps, like I mentioned, we're having this same measure as part of Vigilance, and so we'll have some indication of how families do over time that we can look at, and then we're going to refine some items. We do need to recruit from more underrepresented backgrounds. About 80% of our sample was white, and so finding a way to engage families from underrepresented backgrounds is really important. And then figuring out what's the right utility. Is this a good short-term measure? Will it be sensitive to change over time? Or is this the kind of thing where maybe once or twice, maybe once a year or every other year, it's an opportunity to take stock of your big picture situation as a family, and use that to kind of inform what kind of supports may be helpful. Okay.
Thank you so much. That was wonderful, Dr. Miller. It's so refreshing to see work go into something like this. Caregivers' perspectives are captured from many different angles, but it's nice to see this avenue get some focus as well. Next up, we have a virtual speaker whom you already were introduced to yesterday, but it gives me great pleasure to welcome once again Dr. Brandabur. Dr. Brandabur, for those of you who did not get a chance to hear about her yesterday, is a clinician with expertise in neurodevelopmental disorders. She has previously worked on Parkinson's disease, amongst many others. She is currently a senior medical director in global clinical development at Ultragenyx Pharmaceuticals and closely associated with the CTD program. Melanie, can you hear us?
I can. Can you hear me?
Yes, we can.
Okay, excellent. Thank you again for inviting me to speak today. And you'll have noticed that there are a number of people from Ultragenyx there, all really enjoying this meeting as I am virtually. So sorry I couldn't be with you today, but we really appreciate this time to talk and share some of our planning. So I'm going to share my screen. Okay, can you all see that?
Yes.
Okay, so as I think most of you know, Ultragenyx is always very interested in learning about the patient and the family and what they are experiencing. We don't just make assumptions, or at least we try not to fall into the trap of making assumptions that we know everything about a population that we're studying. So we do a lot of information gathering with things like surveys and groups and advisory boards. And then, of course, as you know, we are sponsoring the Vigilance Study. So we, as you know, as many of you heard in our town hall last year, we are looking at the possibility of developing an oral formulation as a treatment for CTD. So in thinking about how that might work for families, we wanted to get some information on how families are currently taking oral medications and other drugs, and how that was impacted by clinical symptoms of the patients, and how families sort of manage to give medications. Again, we know that this is not the major concern of families. We know that things like intellectual defects and language delay and things like that are much, much more important symptoms. But we wanted to look at the sort of narrow range of symptoms just in terms of informing our process as we think about how we might be giving medication. So just wanted to clarify that. So we know from talking to families that some patients have difficulties with feeding and taking oral medications. And as I mentioned, we decided we wanted to learn more about that in order to think about developing an effective therapy. I think you all know what CTD is, and some of the signs include the major symptoms: developmental delays, cognitive impairment, autistic behavior in some children, seizures in some children, etc. And some patients do have gastrointestinal issues, which could contribute to difficulties feeding and taking oral medication. We've also heard that infants and young children with CTD may have difficulty feeding or gaining weight and may have a diagnosis of failure to thrive. And there can be some persistent vomiting. And we know that in older children, feeding issues may persist, and sometimes behavioral issues can worsen. So our objective with putting together this sort of project was to understand challenges faced by caregivers and individuals living with CTD to inform development of therapies. So we, as part of our learning process, we not only drew from events we'd had before, like a caregiver advisory board and the Vigilance Study, but we also put together some additional questions that we asked, for example, of our Caregiver Leadership Council and clinicians who specialize in treating patients with various creatine disorders. So we drew from a lot of different sources to get as much information as we could. However, we realized that this is probably not the full story. So if you, as I go through this, if you're thinking to yourself, well, my child doesn't do this, or my child does do this, and you didn't mention it, keep in mind, we're still in the process of learning. So we're working with ACD to come up with a survey study that will further add to this volume of knowledge. And so I encourage you to watch for that if you have different perspectives to share, because we're always interested in learning what the families experience. It's a pivotal point and kind of our mantra as we develop clinical programs. So here we looked at a caregiver advisory board, a burden of disease survey that I presented on last year, our CTD caregiver leadership council meetings that we have had over the last year or so. We interviewed 6 leading clinical physicians, some of whom are probably in the room with you right now. And we looked at some learnings from the Vigilance Study. And then we also looked at the published literature to make sure that what we were learning was consistent with what's in the literature. So we've heard from a lot of these individuals that maintaining adequate nutrition and hydration can be challenging in individuals with CTD. We heard about things like diarrhea, acid reflux, choking and gagging as relatively common symptoms in this population. And we heard several times that maintaining hydration was a challenge. We heard frequently that parents reported that children do not seem to be growing proportionally, even when consuming sufficient calories. We heard, for example, about children sort of eating from morning to night as if they were trying to take in enough calories and still not growing proportionally along with their the norms for their age group. In infants, we heard that vomiting is common when babies are nursing or taking formula. Some infants also have trouble latching, and that these factors can contribute in some patients to failure to thrive. Some patients require G-tube placement for nutrition and hydration, and this is a relatively common cause of hospitalization. What we heard is that most of the time vomiting tends to resolve when babies begin solid food. Some families reported that older children and adolescents can develop pronounced food preferences and sensitivities, for example, to extreme cold or hot in food. And sometimes behavioral issues, which may worsen as the child approaches adolescence, might also contribute to difficulties with feeding and taking medication. Some of the things we heard about in terms of taste and temperature preference is that for a lot of patients, lukewarm or room temperature food is preferred. Very hot or very cold foods are often rejected. Sometimes we heard that the experience of eating hot or very cold foods would be perceived as painful for the children. We heard that liquids might be preferred for individuals with sensory issues. Water and milk were preferred over carbonated drinks in some patients. Not all individuals with CTD can use a straw. We did hear that in terms of timing, children with CTD may tend to have the most energy and eat a lot right before bedtime. Again, we heard that they seem to be trying to kind of take in a lot of calories to meet their daily caloric need right up to bedtime in some cases. So we've heard a lot from families about behavioral issues which may worsen as children approach adolescence. And sometimes this can include agitation, aggression, explosive outbursts, and sometimes even self-injury. And as children grow older, this may become more difficult to manage due to a child's size and strength. So in other words, a behavioral issue that might have been able to be sort of squelched in a younger child by maybe like hugging or holding them down or whatever might be harder to do that in an older child now that they are becoming bigger and stronger. We did hear that sometimes older children are more likely to refuse medication and that these behavioral changes may make it more difficult to feed and take medications consistently as adolescence approaches. And again, it's not just confined to adolescence. There are, things that happen at a lot of different ages, but the adolescence one is the one we heard the most consistently from the parents we talked to. So how do patients with CTD take their medications? First of all, we pretty much heard that almost all patients, if not all patients, are taking oral medications. And most patients have difficulty swallowing pills or capsules. So, of course, as parents, parents always figure out a way. And so some of the ways that we heard that parents manage to give oral medications is given via an oral syringe, just kind of popped in the mouth and squirted in there, or in capsules or tablets that can be crushed, sprinkled, or dissolved into foods or liquids. Most children with CTD seem to have some kind of experience with the oral syringe, but we heard that volumes need to be kept low, like about 10 milliliters to be acceptable. And I also heard that if a child, say, has to go from, say, 1 syringe per dose to, say, 3, that would take some getting used to, because the children incorporate these. They're kind of used to this as part of their routine. So if you change the routine dramatically, it may take some getting used to. We did hear that supplements and medications with bitter tastes or gritty textures were a struggle. And clinicians commonly recommended mixing medications with thickened liquids like pudding, applesauce, yogurt, milkshakes, and ice cream. But again, we did hear that some children don't like ice cream because of the cold texture. So some parents described their child having a medication that was dispensed as granules, but sometimes this could have a bitter taste and might change the texture of food or drink unless completely dissolved. Caregivers usually find something that works and continue with that method as long as possible. And I also heard a shout out to ACD, as parents may be struggling with this, and the physician says, why don't you call ACD and see if one of the parents there has some advice on how to get your child to take this medication. So that was kind of nice to hear about parents helping each other in this situation. In infants, frequent vomiting may limit ability to take liquids dissolved in breast milk or formula because they may spit them right back up. Some individuals with CTD learn to swallow pills as they grow older, but I didn't hear that from a lot of parents. Like as with all of us, food preferences can change over time. So it might be good to have a flexible formulation so that if it's being given one way and then resistance emerges, you can switch to giving it in a different form or mixed in a different food or liquid, for example. So in conclusion, oral medications are more likely to be convenient than other delivery routes in this population, but the medications must be carefully developed to ensure solubility, stability, and absorption by the body. Most patients with CTD take some form of oral medication, which often requires the caregiver to carefully manage the habits and preferences of the individual patient. Further understanding patient and caregiver experiences can help Ultragenyx and others develop effective therapies that are easy for caregivers to administer, excuse me, and for individuals with CTD to tolerate and adhere to over time. Collectively, these learnings suggest a manageable pathway for developing future CTD oral therapies. Next steps. More information is needed on the use of oral medication and experiences across age groups, especially in infants and adolescents. We continue to explore dietary preferences, sensitivities, and experiences of individuals with CTD. We want to further understand patient and caregiver experiences, as well as challenges and caregiver perspectives with regard to taking supplements and medication by mouth, and are in the process, as I mentioned, of partnering with ACD to develop a dedicated survey to further explore these topics. Pardon me. So again, as always, our biggest thank you is to the families that are living with CTD and educating us every time we talk to them, as well as clinicians and other stakeholders who contribute to these learnings. As you know, authors are employees of and stockholders in Ultragenyx Pharmaceuticals. The work was funded by Ultragenyx, and we had medical writing support from Carrie Hubbard-Massey, who works for Ultragenyx. So thank you very much for allowing me to present this.
Thank you so much, Melanie, for that wonderful talk. We'll bring you back during the Q&A. Moving on, I'd like to invite Laura Voss. Laura has a master's degree in genetic counseling from the University of Utah. Interestingly, Laura fell in love with genetics when she was first working in a lab using C. elegans as a model organism. And until I read your bio, Laura, I didn't realize that we share that as an interest, because I too worked in a C. elegans lab during my postdoc. For her graduate research project, Laura actually partnered with the association in order to do some work on the development, launch, and initial findings from the Creatine Info Registry. So this is the first bolus of data that you're going to see that comes directly from our registry. So very excited to have you talk about it, Laura.
I'm really excited to be here. Everyone can hear me, hopefully. I feel very fortunate to have been able to team up with the ACD and work with the patient registry. It was a really cool data set to work with, and I'm excited to share what we found. So, I think I'm good. Thank you. So I first want to give an overview of the registry. So it's the Creatine Info Registry, and it's a longitudinal registry that is focused for the international community with CCDS. And it was first created by the ACD as a partnership with the National Organization for Rare Disorders and using their I Am Rare registry program. And that registry program is what it provides the platform that the registry is hosted on, as well as the surveys that go into development and then are distributed. The surveys were developed through the input of the ACD community, parents, and researchers. And it was launched in March of 2021 with phase 1 surveys. And you can find the Creatine Info registry at www.creatineinfo.imrare.org. So the Creatine Info registry is open to patients of all ages that have a confirmed diagnosis of AGAT deficiency, GAMP deficiency, or creatine transporter deficiency. And that's either through testing, genetic testing, or lab values. Currently, the registry is offered only in English, but it's currently in the process of being created in Spanish and French. So patient registries can be an extremely powerful tool, especially for disorders that are rare, have nonspecific symptoms, and that the general medical community have a lack of familiarity about. So when it comes to CCDS, a patient registry can provide a great data set, and ultimately it can enhance our understanding of the natural history of CCDS and its clinical progression over time. With that, it can enable improved diagnosis and therapeutic approach, hopefully allowing for earlier diagnosis and also treatment. And then it can also contribute to a more accurate representation of the community and also just develop a relationship between both researchers and that community. So this is the phase 1 surveys that were rolled out with the launch of the registry, and the number of respondents for each survey at the time of data analysis. I'm not going to go into too much detail about each survey for the sake of time, but I'm more than happy to answer questions at the end about them. And also to date, more than 150 people are registered in the registry, but at the point of data analysis, these were the numbers. So just to go into the results of the Creatine Info Registry, of 103 total participants, 69% have CTD, and 31% have GAMP deficiency. Unfortunately, we currently, or at the time of data analysis, did not have any with AGAT deficiency, most likely due to the rarity of the condition. Earlier on in the research process, I calculated the frequency of GAMP deficiency using the online database Nomad to be about 1 in 250,000, which is consistent with the newborn screening data. And now, thanks to the registry info, we can see that CTD is about twice as frequent as GAMP deficiency, and since it's an excellent condition, we can estimate the frequency in males to be about 1 in 63,000. So this slide provides some of the characteristics of registry participants, and it's broken up by disorder. On the top we have CTD, and it's also broken up by sex, since, as we've discussed a lot this week, females can also present with symptoms. So as you can see, the range of some age at enrollment for both conditions is pretty similar, with participants ranging from 1 to in their 40s at the point of when they enroll in the registry. We also see a comparable average age of symptom onset for both conditions of about 0.7 or 0.8 years, which is about 9 months of age. However, we do see a younger age at diagnosis for individuals with CTD, and that being 3 years as the median versus 5, and thus also having a longer diagnostic delay for those with GAMP deficiency. We hypothesize that the earlier age of diagnosis for CTD is due to the fact that it's been included in X-linked intellectual disability panels that are more accessible than sometimes needing whole exome sequencing or much larger panels for GAMP deficiency diagnosis. So this bar graph, it shows the symptoms reported by participants for both conditions. In black is GAMP deficiency, and in gray is CTD. The 3 most common symptoms that were reported are global developmental delay, speech delay, and seizures. We found that speech delay and low birth weight are more common in CTD than in GAMP deficiency, and seizures, heightened pain tolerance, and behavioral problems are more common in GAMP deficiency. Outside of that, quite a few symptoms are seen in similar frequency between the 2 conditions. So this is now just looking at participants with CTD and their symptoms. On the left are the registry findings for participants with CTD, and in the middle are the findings from a 2013 retrospective study of 101 males with CTD. As you can see, there's similar findings to what have been published for speech delay, seizures, autism features, hypotonia, GI problems, and attention deficits. But a lower percentage of registry participants are reported with behavioral problems. And we do see a higher percentage of registry participants reporting food aversion, feeding difficulties, constipation, and failure to thrive. So now looking at individuals with GAMP deficiency, and the registry is on the left, and on the right we have the findings of a 2014 study of 48 individuals with GAMP deficiency. The registry found comparable numbers for developmental delay, seizures, and movement disorder, but it also helped identify additional features, including heightened pain tolerance and failure to thrive, as well as their prevalence for GAMP deficiency. So this is a timeline that plots the median age of onset for each symptom, and it's looking at both conditions combined. We decided to look at the data in aggregate due to some of the comparable frequencies between both conditions. As you can see, GI problems is one of the first to appear, followed by food aversion, and then failure to thrive. We think that that could be a causative relationship. For example, food aversion due to GI problems, thus causing failure to thrive. Also, we see hypotonia around prior to constipation. that could possibly be due to low muscle tone around the gut causing constipation. The median age of onset for seizures is 21 months, and then speech delay, attention deficits, and autism features are all kind of noticed in sequence, and that could be due to those findings contributing to the diagnosis of autism. So this bar graph details the number of healthcare providers seen prior to receiving a diagnosis of CCDS. And then on the right is a table that provides the numbers, so how many participants saw X number of providers. The mean number of healthcare providers seen prior to receiving their CCDS diagnosis is 4 for both conditions. And we also found that about 40 to 50% of participants had to see at least 5 different healthcare providers in order to receive their diagnosis. And this really speaks to the diagnostic odyssey so many patients face. Having to see multiple providers means a lot of different referrals, appointments, time, and just cost, both financially and emotionally, and just that energy that goes into seeking that diagnosis. And this bar graph details the different healthcare providers that diagnose CCDS in the participants. So we saw that in most cases it was a geneticist or a neurologist or a metabolic specialist when available. And this slide provides the diagnostic test that provided the diagnosis to the participants. We saw that genetic testing is the most common diagnostic test, which makes sense due to its shorter turnaround time and the reduced cost, and that allows a lot of accessibility. Also, others being diagnosed with MRS or biochemical testing. And we are seeing more individuals being diagnosed with family history or newborn screening in the case of GAMP deficiency. And then this table is from the 2013 study of 101 males with CTD. They found that the most common test at the time of their study was biochemical testing. So it shows that we are kind of shifting to more genetic testing as time progresses, which makes sense due to the increased accessibility. And finally, I wanted to share some patient comments that were provided when asked about their experience with having a patient with CCDS. And I think it emphasizes the importance of just continuing to study these conditions, spreading awareness, and just continuing to work together to further our understanding. This is from a father of a participant with CTD. He said, "It was a long journey to get a diagnosis. Without seizures, few clinicians were interested in finding the root cause of the developmental delay, and just a half an hour or hour visit is not indicative of the severity of the global developmental delays, particularly in children that have many hours of therapy to compensate for the widening between them and their peers." And from a mother of a participant with CTD, she said, "Most doctors counseled me not to seek further medical testing or therapy. I was counseled to wait. This would have meant delayed therapy when therapy is the only thing that can currently help a child with CTD. If my child had GAMP instead of CTD, waiting would have caused irreparable harm. Doctors are not sufficiently educated about CCDS, and their ignorance can harm their patients." And with that, I just want to thank the ACD for allowing me to go through their data set and all the families who have participated. If you have yet to check out the survey or enroll in the registry, you can find it there again. Thank you for your time.
Thank you so much, Laura. That was a really nice presentation. Your last 2 slides on the comments from caregivers really underscore the importance of symposiums like ours, where we strive to increase awareness and educate about options that are available to families, but also equally underscore to the clinicians and academic members of our consortium that we do need to spread the word. We do need to communicate to the rest of the people in our networks that there are ways to identify this as steps that need to be taken. So thank you for that. Moving on to our next speaker, Dr. Curie. You have all met her yesterday. She was part of our clinical panel. But before we get to that, I'd like to invite our moderator for this session, Dr. Andrews. If I can invite you up to the stage along with our other speakers. And if we can also bring up Dr. Brandabur on screen. Great. Melanie, can you hear us?
Yes, I can. Thank you.
Okay, great. Just as a reminder, I will be passing along the mic in the audience. Because Melanie cannot see us, it would be great if you could introduce yourself when you ask a question. Okay. Dr. Andrews, over to you.
Thank you very much. I would like to thank to all speakers for their very interesting and excellent presentations. And I'm going to start with my simple questions that you can have more time to ask your questions. Now, the first speaker is Kim. Kim, that's a great study, actually, what you shared with us. I was wondering, what was the age group of the participants?
Yeah, so it was very different. I think I remember there was one patient who was even 30 or like 32, and there were also really young patients, even like 1 year old.
Especially for older patients, did you have any patients completing any questionnaires for you, or did you interact with parents only?
Yes, parents only.
And is this guide that you prepared nicely is available in ACD homepage and extraordinary homepages as well?
Not that I know of, but I can talk to them to try and make it work.
That would be great because it will be used in broader people. Then my second question is to Dr. Miller. And her title was Measuring Family Adjustments and Accommodations in Intellectual and Developmental Disorders. Actually, this is a very important study. I understand lots of questions are there. Sometimes it can be tired, some to answer. Is there a plan in place to validate that can be used in clinical trials if you have simplified your questionnaire?
Great question. Interestingly, one of the feedback questions we asked was this too long? And only a small number of parents thought it was too long. Most clinicians and researchers think it's way too long. But the parents, so I don't know if that was because the parents are like, I answer 5,000 questions, like this is just 100, it's not even the longest thing I've ever done, or if it was, a lot of parents said, no one's ever asked me these kinds of things. So it might have been that it was interesting and it was a different thing. For a clinical outcome, that's the next, it's a trick because you can accommodate, like I was saying, like you're gonna accommodate throughout your child's life. And so so we have to figure out, like, is this something that is gonna be sensitive to change in a clinical trial, or is this something that is just capturing the broader experience? We do have a section on there that's about specific behaviors, and some researchers have looked at that and said, well, let's focus on that and see if the behaviors are changing, then that can be a good indication that other things are changing, which is great, but that's a separate sort of question. And there may be other measures that already are doing that. So I don't know if it's really unique to add that piece. And I also am not sure that it's appropriate for a short-term clinical trial to look at family accommodations, because these are big decisions that people are making. So it might be the kind of thing where it can have an impact over like a 5-year period, but maybe it would be inappropriate to think that something as big as your family organization would change in a short trial. Does that make sense? So I don't know.
That's great. Thank you very much. And I'm going to move to Dr. Brandabur, who kindly shared study results for oral medications and difficulties taking oral medications from the taste perspective, as well as the feelings or difficulties for CTD patients. Of course, there were lots of information about it. And do you think those informations would help Ultragenyx to design the best oral medication for the future clinical trials?
Well, that's a good question, Dr. Andrews. We hope so. Obviously, there are a lot of other things that have to go into that decision-making process, but we thought it would be foolhardy to leave out this important piece as far as finding what is important to the families and what they do every day in terms of managing to get medications into their child. So it'll definitely be a very informative piece of the puzzle, no question. And again, for other people as well who are developing therapies, I think it'll be helpful.
That's great, because it's very important for the compliance, for the clinical trials. That's why
Exactly.
You are doing great, actually. Thank you. Then my next speaker is Laura. Thank you very much for summarizing the great registry information with large amount of information. You kindly showed us some of the subgroups for questionnaires, but you didn't have time to go into the details. I was wondering about the subgroup of participant profile survey. What was included in general?
Yeah, that survey mostly looked at demographic questions, so country of origin, race, that was age, yeah, just general demographics.
That's great, thank you. And you also kindly mentioned the genetic diagnosis, shifting the diagnostics from biochemical to genetics. What do you think, other than the easy availability of this testing? Because the biochemical is very specific, and then genetic is more untargeted. Would you comment on that?
Yeah, I think it could be a couple potential reasons. If you're in a neurology clinic and they do one of the just X-linked intellectual disability panels without even being aware of CTD and just catching it that way, quite possibly, or now with whole exome sequencing being more accessible, you could quite possibly catch it that way too. So maybe not needing is maybe the wrong word, because specialists are really important, but having people who aren't even aware of CCDS kind of stumbling upon it thanks to the accessibility of that testing. Not to make that the answer again, but genetic testing just coming up a lot sooner.
I think it became the first-line testing for many clinics, unfortunately, or fortunately, because it increases the diagnosis, as well as we diagnose atypical presentations, late-onset forms. Of course, those 3 genes for creatine deficiency disorders, they are also included in epilepsy panel. You kindly showed us epilepsy is about 60% in creatine transporter deficiency, more than 80% in GAMP deficiency, which means either epilepsy panel or intellectual disability panel or exome sequencing will increase the number of patients that we are seeing. Great. Our last speaker was Dr. Curie, a very interesting study that you shared with us today, a large number of patients that you applied the testing. It's very impressive. The only question I would have when we look at the traditional neuropsychological assessments that we use, depending on the compliance, test might last from 1.5 hours to 4 hours. And what is the time frame for those tests? If you combine everything together, what would be?
We were really planning to have quick tests, quick assessments, because also, given what I said yesterday, that we believe that it could be very interesting before launching very large clinical trials, maybe to use it using a skate design, for example, in a one trial. So we did want to have the ability to test and retest, and we designed everything in order to be able to test patients at home. Because it's not our idea first, it was because we had a contact with the Extraordinaire Association, Carol and Mr. DeFranco, and they really emphasized the need for them, I mean, as parents, to be able to assess the evolution of the child, but without, having to come back and forth always, and if everything could be, I mean, not everything, it's not possible, but if some assessment could be done at home, it would be also interesting. So we are going to test that, on internet supervision, like Zoom supervision, and we'll see if it works or not. But each test is very fast, so it lasts a few minutes. So it's really fast.
That's great, because maybe less than 15 minutes time frame, you may complete all those tests.
Yeah, like 20 minutes, yeah.
And the next, I'm going to leave the validation question to Sangeeta, because she's very interested. It's a burning question that we have. Do you think, because it seems that you apply the test in different type of intellectual disability patients, and do we need to modify it for CTD to be able to use in clinical trials?
So before we validated another task. It's published and we have a patent for it. It was very interesting, but it was inspired by the Ravens matrices, but really very much simpler because it's too difficult. Even the color matrices are really too difficult for ID patients. So we designed that, but we validated it on children above 4 years old, but we thought that it was too difficult for CTD patients. That's why we designed this task, really, the match to sample task, especially to be able to test this. I mean, we think that it's quite adapted to the CTD patients, especially.
That's great, thank you. It's for the floor now.
Hi, thank you all for your work. We appreciate it. I do have a couple of questions for Dr. Curie. So some of these tasks are similar to what my son's been, doing in therapy and at school. So my questions were, if it's the parent initiating the test, then I suppose we could ask the question in our own way. Like, for example, my son would be, find the same, or something like that. And if it were a random tester that might say, match, he might not understand what you're saying. So is that why you designed it that way? Or?
So this is exactly, it's a very interesting question. Thank you for it, for asking it. We believe that because most of CTD patients have really a language impairment, we designed the task in order for them to have really minimal language instruction. So we have a very strict protocol, and the neuropsychologist in my team and master students who did perform the task, we do not want to influence, because we really did want to have a task able to be done by the patients without involving a lot of language and difficult sentences, everything. This is why we designed these little, Disney characters, just to engage them in understanding how it works, and because it's turns around, when you find the right answer, it just very implicitly explains to the patient. I mean, they understand it very implicitly because they test, they try, and it moves, and then they would like to find, it's rewarding by itself to have something which is moving. So this is the way we designed it.
Okay, so no question is asked at all?
No.
Okay.
No.
And then you just gave...
I mean, we for this task, of course, I'm not saying that it is not important to assess language, of course.
No.
But
no.
To have an ability to test for reasoning abilities in these patients without involving too much language and complex sentences, I thought it was a good idea. But maybe you have a different
No, I think that's good. So, but the other question that I had was, you said there's an incentivizing response for correct answer. Is there, and then is it static for the wrong answer?
Yes, it is.
Yeah,
It
because
is.
I'm just thinking of some
No,
toys that my son has, and sometimes the wrong answer is more incentivizing for him than the right answer.
Yeah, that's a very good comment. I mean, we assumed that it was more interesting to have something moving than something fixed. But if you disagree, I'm available to discuss that afterwards. No worries.
Hi, I'm Nathan. I'm a CTD dad. My question is relating to the registry, and I'll try to condense it as much as I can. But I think we've heard a lot today and yesterday about kind of the larger, I don't want to use the word cure, larger treatment for the CCDS conditions themselves. And then we've heard a lot about the detection for people with the conditions. I think one of the areas we didn't hear much about is discussion on getting after the individual symptoms, whether it's the seizures and epilepsy, whether it's the feeding problems. How valuable would you say the patient registry is going to be in driving the research towards those specific conditions and getting the scientists and the doctors on board with looking at how do we treat epilepsy in kids with CTD, or how do we treat weight gain issues in kids with CCDS?
Yeah, and I'd love to hear also if Emily has any thoughts or anyone else from the ACD, but I do think, so the findings that I presented were just these very initial, like, let's get a picture of our population and just establish that first, and then over time, more surveys are being rolled out in kind of a conversation with different like family groups that are advising kind of these surveys and what information they're collecting. So I think, to answer your question, the value to clinicians potentially, or for developing treatments, the more information we can gather potentially in these surveys that are asking about these different symptoms, I think that can be valuable to present to anyone to provide further evidence on why what we're asking for is worthwhile. But if there's anything anyone at the ACD
I can add to that. Absolutely, I think that's one of the goals. Of course, I think the primary goal is to just get more richer information on outcomes that might be utilized in the context or have utility in the context of a clinical trial. But absolutely, they will also highlight areas for further inquiry.
I can maybe touch base for the epilepsy part, because we don't know which anti-epileptic medications are working properly. That's why the epilepsy survey is still underway. We are working on it. And we will especially look at the seizure outcomes with specific anti-epileptic medications that we can help families providing the information.
I'm gonna add one comment to that rather than a question. It's interesting that you saw more response on failure to thrive than behavioral problems, and I think the interesting thing there would be to compare that to age group, which then I'd add to, like, when you're gathering this data on surveys and history, it's probably quite age relevant then, and so then the question is whether you want to keep doing surveys on the same patients at later dates, because what's important or what you're seeing might change, because you might not have behavioral problems at 8 months, but you're going to at, say, 6, right? So that wasn't going to be my question. My question was actually on the testing, which I think it's fantastic that you're trying to come up with a test for ID. My question would be, what would you do when you're doing a study if you have ID patients who, especially in the CTD population, are often on medication for ADHD or hyperactivity? I would get a very different answer, probably, or test score in your testing, whether my child was on or off medication.
This is for me, is that right? I think I would answer maybe not specifically for CTD, but more generally speaking with ID patients who are under, for example, methylphenidate. I will take a comparison. So maybe it's because I'm a little bit jet lagged, so I'm sensitive to that. But I think that we can compare, it's fair, I think, to compare ADHD with what everyone has experienced, because I'm not sure that some of you maybe have ADHD, I don't know, but it can be really comparable to what we experience when we are really tired, that sleep deprivation, I mean. And I think that, in my opinion, it's fair to give them basically the ability to demonstrate their best abilities. So I think that I would rather do the testing using if it works, if the child is better under methylphenidate, for me it's better to have the best estimate of what he can do. It's more positive for him, for the family, for us too, because we can see what can be possibly achieved by the child. Personally, I think that it is very important to, when we assess a child, no matter what test we use, to be able to find out what he can do and basically to reveal his strength, at least as much as what can be his weaknesses, or we all have some, but it's very important for me to have that in mind when we talk about assessment. So it makes sense for me, yes, I would say.
I wanted to add one thing to that. We have a tradition in the US for some reason of when kids with ADHD come in for testing, we often say, don't take your meds for testing, which is so weird because if you're testing for ADHD, then sure, that's helpful. But to tell somebody, I want to see what your intellectual ability is, but don't wear your glasses. Like you would just never do that, right? So I think it depends what you're doing, and I totally agree. If you're trying to see what can this child do, then you address the things that you can address. Like you wouldn't tie one of their hands behind their back and then ask them to, draw a picture, right? So I think it would make much more sense to give medication if they have ADHD. And if you're in a situation where somebody's trying to test your kid without ADHD meds, ask them, are you testing for ADHD or are you trying to see what they actually can do?
I have a question and I have a word of caution for Laura. This survey, this registry is excellent, and really the amount of data that you are collecting, the buy-in from all of the families and so that's wonderful. And I really look at those data with very much interest. But the question, of course, is how do you assess those findings? And what you presented was to some degree misleading. So I give you a couple of examples. You compare GAMT symptoms and outcomes in this survey with transporter, right? So for example, GAMT had a little bit more seizures than transporter. But what you don't say is that 80% of the respondents in the GAMT group are on a treatment that works, while basically nobody in the transporter group has an efficient treatment for the disease. So now you are showing something that makes those conditions appearing very similar in an outcome that is very different. Yeah. So that's just a comment to this. The other thing is you compare rightfully the published data with what the registry finds. And again, transporter, there should be quite a similar outcome with this registry and what has been published. But if you look at historical GAMT data and this registry, we should see a difference because we have made progress. So that's the comment. And just a brief question, I saw 17% of CDD patients had normal speech development. So 7 kids. And I'm surprised about that.
Yeah, and I forgot to mention for the hallmark findings you would expect for CDD, like speech delay, it not being 100%, those folks who weren't included and were perceived as not having it were too young at the time of enrollment to have speech for anyone. And I think that also goes for the questions and to kind of address your comments, I agree that when one condition has a treatment, the other doesn't. It's a, kind of apples to oranges. And some of those questions for GAMP deficiency, or they were asking about these symptoms appearing at any point. So we do have individuals who have been diagnosed very early on, have been receiving treatment thanks to family history, newborn screening, in the same kind of data set as folks who it might have been when they were 5 or 6, so they had the opportunity to have manifestation. And it was kind of trying to figure out how to best present this data. And I do promise in my larger format of this presentation, I go into that to try not to mislead. And your question, oh man, I'm sorry.
About speech?
Oh, sorry, I didn't answer that, so we're good too. Okay, thank you.
I do want to add, I think we're pressed to present certain data in 15 minutes and to sort of set up the full context for it, which is basically difficult. I'd urge everyone to, we're going to make these registry data public, where there'll be recordings and eventually publications, and you can obtain the full context there. And furthermore, to add color to some of the effort that Laura's been pursuing, I think it illustrates the heterogeneity of the community and the population that we're trying to study, right? It is true that some of them have access to treatment, some have been on supplements for longer, and all of that underscores the fact that this population is heterogeneous. Does that mean that they should not have appropriate drugs that can still resolve pending difficulties, for lack of a better word? No, I think it underscores the need to be able to understand the population, understand different age group and different concerns, and try to find something that fits for all of them. I'll conclude with that. I think we're almost out of time. We've exceeded our time allocation for this section. So thank you all, speakers, as well as Melanie, for joining us remotely.